Welcome to part 1 of the Prevention, Diagnosis, Treatment and Following Heart Failure webinar recording. This webinar was recorded on the 5th of November 2021.
Hello, you're welcome for the Wonka Europe webinar, and we have our colleagues in prevention, diagnosis, treatment and following a heart failure is our subject tonight. We are very happy to be together with you. And our guests are from, both of them probably. One of them is a family doctor, Dr. Richard Hobbs, and the other one is Dr. Sadi Gulec, who is a specialist cardiologist. And this is the format of the meeting. So, hi Sadi. Hi Richard.
Hi there.
It's
Good
very
evening.
Together with you. I just wanted to introduce you, Richard, first of all, and then I will introduce you, Sadi, very shortly, although it's very hard to introduce both of them because they have a very huge CV. But on the other hand, I know that you know their specifications about their professions. Let's start with Dr. Richard Hobbs, and he is a professor of primary care, health sciences, and National Institute Health Research School, English School for Primary Care Research in Oxford. Richard is the Nuffield Professor of Primary Care at the University of Oxford and head of the Nuffield Department of Primary Care Health Sciences. He has served on many national and international scientific and research funding boards in the UK, Ireland, Canada, and the WHO, besides having many other publications. Where we as Europe know him is mainly due to his current position in the Wonka Europe as the chair of the European Primary Care Cardiovascular Society, a Wonka Europe's special interest group. Richard will tell about the importance of the heart failure and difficulties in prevention and diagnosis in general practice, including the diabetes mellitus relation with the heart failure, prevention and difficulties in diagnosis, and of course daily problems. Dr. Sadi Gulec is a professor of cardiology working in the cardiology department of Ankara University School of Medicine. He worked with the Cleveland Clinic Foundation in the USA. He is a member of the European Society of Cardiology and Turkish Society of Cardiology. He has served in the scientific board as well in working groups of both societies. He is vice president of the Turkish Metabolic Syndrome Society right now, has many scientific projects and publications besides authored interesting books, which are, to my opinion, really very enjoying and informative when you read. And they are in Turkish, dedi doctor, and angio olmanız gerekiyor. Those are in Turkish, but I think they are very interesting if one day he translates it into English also. Some of you may remember his incredible presentations and performance, making things easier for us to digest in primary care-oriented conferences with his unique style. We are grateful that he accepted to talk here as it was last-minute requests from him and as he normally is full for the whole year. Thank you, Sadi, also. And he will talk about tips and tricks in chronic heart failure management. He will highlight new medicines in the optimization of medical treatment section in his talk. So, about the rules also, each speaker will talk 15 minutes in total, and then question and answer sessions of 10 minutes and ending. I would like to remind you that on the right side there is a question and answer sections which you can write, and I can see the questions, and then I can forward it to my guests. Just we can start to follow the presentations, the videos of our colleagues. We are here live and we can start.
Hello, I'm Professor Richard Hobbs, Professor of Academic Primary and Head of Department at the University of Oxford, and I'm very pleased to be talking to you about the subject of heart failure today and the care contributions needed from primary care. So let me just share my slides with you. My disclosures are on the bottom of the slide there. So what I'm going to particularly focus on now are how we should be diagnosing and treating heart failure, but I'm going to start off with why it's so important. It's one of the few cardiovascular diseases that are on an increase in prevalence, and that's at least partly because we are better at helping patients survive major cardiac events such as myocardial infarction and acute coronary syndromes. So it's common, and it's getting more common, and its significance is that it has a high impact on patients. I'll show you data around that shortly, but it also has high impact for health systems because it's actually the most important reason for numbers of hospitalizations in many health systems, and therefore it is a high cost condition to treat. And despite many evidence-based medicines, it's still a condition associated with a very poor prognosis. So in terms of causes, just to note that these are usually vascular causes. So the common precursors to heart failure are coronary artery disease, as I say, leading to coronary events and hypertension. But increasingly, valve disease and arrhythmias is also associated with cardiac muscle dysfunction, often with preserved ejection fractions, but nonetheless associated with pump disorder and therefore heart failure. Now, importantly, patients obviously will get symptoms associated with heart failure, and often that does occur in primary care. But as you can see from this slide, often, unfortunately, the symptoms associated with heart failure are common and relatively vague, such as fatigue, reduced exercise tolerance, and generalized breathlessness, or some lower extremity edema, very commonly occurring within patients, and many different causes that may produce these symptoms. Hence, one of the big problems associated with heart failure is it often isn't diagnosed early in primary care, and often patients need to get more severe symptoms before their condition is diagnosed. So let's just rehearse why heart failure is such an important topic. And let's focus on patient impacts initially. And as I've said, it already has a particularly bad influence on prognosis. These are data from our own ECHOS cohort, which is now nearly 20 years of follow-up of patients who were screened for heart failure and what happened to them. These are data at 10 years showing the proportions of patients who had actually died with heart failure. So over 70% of the cohort of patients had died at 10 years compared to mean survival of only, 25% of patients who did not have heart failure had died from other causes. So clearly dramatically impacts on how long you will live for once you develop the diagnosis. And these are also data from primary care. They're UK data, but to be honest, I expect they would be replicated in most countries in Europe. Real-world studies suggest that this is the case, that effectively this is looking at time along the bottom line over a near 15-year horizon and survival on the y-axis. And basically you can see there has been very little improvement in heart failure prognosis over that extended period. Now, I wouldn't describe this necessarily as a complete failure of healthcare, because what this has been also associated with is a worsening of risk factors within the general population, rise in obesity, rise in rates of hypertension, etc., and also higher proportions of people developing heart failure. So perhaps we could describe this as medical systems perhaps have stemmed what might have been increasing, worsening mortality rates, but they really haven't impacted on improving mortality rates. And as I've said, an important take-home message from here is that we need to get better at managing existing heart failure because it's a condition that's likely to get more common over time. So as well as affecting how long you survive for, it also has a dramatic impact on quality of life. Again, these are primary care research data, again from the ECHOS cohort. Looks complicated, but basically this is the quality of life using the SF36 validated quality of life score. And this reference point here is the general population. So we had a very large number of patients screened in ECHOS, and we were able to measure the quality of life of everybody who didn't have these target conditions below. And you can then reference the disease population to the population who have these defined diseases here, looking at the 6 modalities of SF36, which looks at physical functioning, role physical, role mental, social functioning, mental health, energy levels, physical score and overall health perception, pain score, and overall health perception. And basically a 0.1 deviation from the Z-score reference point is considered clinically significant. And so you can see here that stage 3-4 heart failure is associated with really huge reductions in quality of life, affecting the physical and social measures of quality of life and overall health perception, worse than many other conditions, including things like arthritis, chronic bronchitis and depression. And indeed, a quality of life associated with heart failure approximates to that considered by patients with cancer. However, as if that wasn't enough, heart failure, as I've already suggested, does have a big impact on health system cost, and that's because heart failure is a common cause, not just of admission, but perhaps even more important, of readmission. Patients who are admitted to hospital are very likely to be readmitted, often within a short time. This is less than a month, around 6% of patients being readmitted. But over a 12 months, approaching 20% of patients actually get readmitted, and it's the commonest cause of readmission in developed health systems, and therefore the associated costs associated with that. And just by way of comparison, heart failure with preserved ejection fraction, these are rates of hospitalization much greater. These are preserved ejection fraction heart failure trials. And if you compare it in this instance with the hypertension trials, much higher rates of hospitalization in patients with heart failure. And as if that wasn't bad enough, each time you get admitted to hospital because of heart failure, your length of stay increases, and therefore the costs associated with that admission become greater. So I think that really illustrates why this topic is an important one for us to consider. And perhaps we can think about what we could do to improve those data. And the first thing is to think about how we diagnose this condition, having already said that it's not necessarily easy to pick up in the early stages because the symptoms are so common. Basically, the recommendations, these are based on ESC, but it's true with all international guidelines, recommend that if there's any suspicion of heart failure, then you should arrange, if you've got access to it, a natriuretic peptide assay, NT-proBNP or BNP. And if this is raised, these are the cutoffs recommended by the ESC for NT-proBNP above 125 picograms per mil. If they're raised, then you should refer the patient for echocardiography. That should be read by a well-trained individual, because some of the changes noted in echocardiography are subtle, particularly that in preserved systolic heart failure. And if there are any abnormal findings, then you basically differentiate the patient into heart failure in the subtypes of heart failure with a reduced ejection fraction below 40%, heart failure with moderately reduced ejection fraction, those with 41 to 49%, and those above 50% ejection fraction who are labelled as heart failure with preserved ejection fraction. Very important that this objective assessment is made. The key here that's transformed diagnosis in primary care is the availability of natriuretic peptides. We have done work in primary care looking at validated validated clinical systems that can help you determine on clusters of symptoms and sign who is most likely to have heart failure, and really quite good sensitivity, but rather poorer specificity associated with clinical decision rules, and they don't add anything to BMP alone. So that is the test of choice in primary care, is to do a simple blood test, and that determines whether the patient probably has heart failure or probably doesn't have heart failure, and then triages them for an objective assessment of heart failure function through echo. Now, in some health systems, one has to accept, unfortunately, access to BMP is not available, and anybody with suspected heart failure should be referred on either to a specialist clinic or to open access echocardiography. So just turning briefly to management, this is going to be mainly covered in the second talk today, but let's just consider some issues about heart failure management, and I'm going to talk about how well we're currently doing, why those trends exist in terms of how well we're doing, what we should be thinking about in terms of improving management, and finish very briefly on reinforcing this message about new recommendations for treatment. So in terms of current prescribing, we obviously have had data around ACE inhibitors, beta blockers, and MRAs for really quite a long time, for approaching 20 years. And yet, in primary care in many countries, unfortunately, not all patients who have a label of clinical heart failure are actually on these treatments. All sorts of reasons for that. If we look at hospital specialists, then even in hospital practice, not all patients are actually on an ACE or ARB beta blocker and an MRA. Much better than in primary care, one has to say. But even in hospital practice, if you look at the proportions of patients who are actually on target dosing, then it's a minority of patients. So big take-home message is that patients who have a diagnosis of heart failure should be being offered these evidence-based treatments. And more importantly, they don't just need to be on the therapy, but they need to be on the therapy at the target dose, which for most of these medications is the higher dose range. Otherwise, as these data show, if you are prescribing under half of what the recommended dose is, you are basically doubling the adverse outcome. In this instance is death associated with heart failure. So there is a big issue currently in medicine that we are diagnosing heart failure often late, we are initiating treatments late and in suboptimal doses, and that is associated with worse outcomes. So let's think about why there may be some undertreatment in primary care. And one of the reasons for that is the one I started with, which is the symptoms are common and vague. And indeed, many patients with heart failure do have other comorbidities, in particular COPD or renal dysfunction or diabetes, which might be thought of as the explanation for the symptoms. But if you look at any screening data of these sorts of populations, you will find hidden heart failure. So this study from the Netherlands in primary care screened patients who were diagnosed as having COPD, and in fact only half of them had only COPD. A third of them didn't have COPD or heart failure, but 20% here had heart failure either associated with COPD. So if you were only treating the COPD, you were missing one of the reasons why the patient was symptomatic. And in fact, 8% only had heart failure, didn't have COPD, and would therefore be on quite the wrong medication. This would be replicated with any of those comorbidities that I showed you on the previous slide. So in terms of management of heart failure, these are the priorities. We are treating both to prevent disease progression, reduce mortality, and prevent hospitalizations. But we also have these other important reasons for be treating, because all these evidence-based treatments that reduce disease progression also improve patient health status, because they improve symptoms, improve quality of life, and improve functional capacity. Very important reasons to prescribe. Even if you didn't want to prevent demand on the health system, you're going to get individual patient gains. And I think the consequences of some of the things I've talked about is that diagnostic uncertainty leads to undermanagement, and that means we need better access to diagnostic testing, particularly natriuretic peptides and echocardiography services in primary care if we're going to do better. And I think the other issue that causes a bit of debate is the one I referred to, is that sometimes people think if you've got a very elderly person, perhaps extending life might not be an ideal, particularly in somebody who is who has a very poor quality of life. But of course, as I've said, these treatments actually improve quality of life, and that means we need better agreement with patients about what the aims of treatments are, and therefore what we would be doing in terms of both initiating and up-titrating treatments. And in primary care, one of the best ways of achieving that is having specialists in primary care, or GPs with special interest in vascular disease and heart failure. And if you organise yourself in primary care around those sorts of services, you develop a small team within primary care that looks after heart failure, then it does have quite a dramatic impact on outcomes. So I'm just going to close now by a very brief resume of the changes to the guideline recommendations. We need new treatments in heart failure because although existing ones can be pretty effective, you've still, even despite that, got very high residual risk in patients, even with the existing treatments. And therefore, we are going to carry on looking for newer treatments in heart failure. And again, looking at ESC guidelines replicated in most countries now. Fortunately, we have a number of treatments that have shown significant benefit, and supplementing the ACE and ARNI and beta blockers a few years ago were the mineralocorticoid blockers, and now SGLT2 receptor antagonists have been added to the list of treatments that are effective in heart failure, with diuretics used in patients with edema. Now, biggest change has been over the SGLT2 inhibitors, and between 2016 and 2021, the guidelines changed from a possible should be considered on the basis of evidence then to class 1. This is the best evidence available. Are recommended in all patients with reduced ejection fraction heart failure. And in fact, there's no evidence in patients with preserved ejection fraction function. And this is based on huge outcome trials with the SGLT2s. This is the DAPA-HF, showing a big impact on important clinical outcomes of worsening heart failure or CV death. Very similar relative risk reduction also seen in the Emperor reduced trial. So very large evidence base, changing guidelines, additional therapeutic area for us to consider. So in summary, I think hopefully what I've shown in the last few minutes is why heart failure is such an important global problem, that the treatment goals are both to reduce the impact on health systems, but also to improve quality of life in patients. And that is best achieved by a multidisciplinary approach to care. And that will involve us educating ourselves better about heart failure and how to manage it, us sticking to guideline recommendations better, and that is particularly around treatment optimization. But a very important lesson to us is to diagnose earlier when patients are in earlier stage heart failure, and indeed to try and prevent more heart failure downstream by reducing the impact of vascular risk factors such as those with elevated lipids and hypertension. Thank you very much.